Bismillahirrahmanirrahim. Assalamu alaikum. This is me Nazir Ahmad from Pakistan. Today our topic of discussion is design and optimization of dosage regimen. New on my YouTube channel, please subscribe to my YouTube channel and press the bell icon button so that you may not miss any upcoming video. Design and optimization of dosage regimen. To initiate drug therapy, the clinician designs a dosage regimen administered either by continuous infusion or in intervals of time and dose, depending on various patient and drug factors, including how rapidly a steady state rate of administration equals that of elimination must be achieved. The regimen can be further refined or optimized to achieve maximum benefit with minimum adverse effects. Design and optimization of dosage regimen consist of following steps. The first one is continuous infusion regimen. The second is fixed dose, fixed time regimen. And third is optimization of dose. And further are their subheadings such as plasma concentration of a drug following IV infusion, influence of the rate of drug infusion on the steady state, time required to reach the steady state drug concentration, exponential approach to steady state, effect of the rate of drug infusion, rate of decline when the infusion is stopped, multiple IV injections, effect of dosing frequency, example of achievement of a steady state using different dosage regimens, multiple oral administrations, maintenance of dose, loading dose, dose adjustment. Continuous infusion regimens. Therapy may consist of a single administration of a drug, for example, a single dose of a sleep-inducing agent such as zolpidem. More commonly, however, therapy consists of continued administration of a drug, either as an IV infusion or in oral fixed dose, fixed time interval regimens, for example, one tablet every 4 hours, each of which results in accumulation of the drug until a steady state occurs. Steady state is the point at which the amount of drug being administered equals the amount being eliminated, such that the plasma and tissue levels remain constant in the case of IV administration and fluctuate around a mean in the case of oral fixed dosage. Number one, plasma concentration of a drug following IV infusion. With continuous IV infusion, the rate of drug entry into the body is constant. In the majority of cases, the elimination of a drug is first order, that is, a constant fraction of the agent is cleared per unit of time. Therefore, the rate of drug exit from the body increases proportionately as the plasma concentration increases. Following the initiation of an IV infusion, the plasma concentration of drug rises until the rate of drug eliminated from the body precisely balances the input rate. Figure 1.22 it indicates a steady state input rate of infusion equals output rate of elimination. Thus, a steady state is achieved in which the plasma concentration of drug remains constant. Number subdivision is 1.1 influence of the rate of drug infusion on the steady state. It can be shown that The steady state plasma concentration is directly proportional to the infusion rate. For example, if the infusion rate is doubled, the plasma concentration ultimately achieved at the steady state is doubled. Figure 1.23. Effect of infusion rate on the steady state concentration of drug in the plasma. RO, rate of drug infusion. CSS, steady state concentration. Note: a faster rate of infusion does not change the time needed to achieve steady state, only the steady state concentration changes. High rate, low rate of infusion. This is graph between plasma concentration of drug and infusion time. Furthermore, the steady state concentration is inversely proportional to the clearance of the drug. Thus, any factor that decreases clearance, such as liver or kidney disease, increases the steady state concentration of an infused drug, assuming volume of distribution remains constant. Factors that increase clearance of a drug, such as increased metabolism, decrease the steady state concentration of an infused drug. Second division 1.2, time required to reach the steady state drug concentration. The concentration of drug rises from 0 at the start of the infusion to its ultimate steady state level. CSS, see figure 1.23. Here, the time start from 0 and increasing slowly and achieving steady state level. The fraction rate of approach to a steady state is achieved by a first order process. Number one, exponential approach to steady state. The rate constant for attainment of steady state is the rate constant for total body elimination of the drug. Thus, 50% of the final steady state concentration of drug is observed after the time elapsed since the infusion. T is equal to T1 by 2, where T1 by 2 or half-life is the time required for the drug concentration to change by 50%. Waiting another half-life allows the drug concentration to approach 75% of CSS steady state concentration. See on next figure 1.24. The concentration is 90% of the final steady state concentration in 3.3 times T1 by 2. Thus, a drug will reach steady state in about 4 half-lives. Figure 1.24, rate of attainment of steady state concentration of a drug in the plasma. It has plasma concentration of drug versus time graph. And here start of drug infusion and drug infusion stopped washout begins. This is steady state drug concentration. CSS for 50% of the steady state drug concentration is achieved in half-life. This is 50% and 90% of the steady state drug concentration is achieved in 3.3 half-lives. This is 90%. The washout of the drug is exponential with the same time constant as that during drug infusion. For example, drug concentration declines to 50% of the steady state level in half-life. This is washout of drug. Number two, effect of the rate of drug infusion. The sole determinant of the rate that a drug approaches steady state is the half-life, and this rate is influenced only by the factors that affect the half-life. The rate of approach to steady state is not affected by the rate of drug infusion. although increasing the rate of drug infusion concomitantly increases the rate at which any given concentration of drug in the plasma is achieved. It does not influence the time required to reach the ultimate steady state concentration. This is because the steady state concentration of drug rises directly with the infusion rate. See figure 1.23. Number 3, rate of drug decline when the infusion is stopped. When the infusion is stopped, the plasma concentration of a drug declines, washes out to zero with the same time course observed in approaching the steady state. See figure 1.24 again on next slide. Here they are showing this one. When infusion stops, the washout of the drug is exponential with the same time constant as that during drug infusion. For example, drug concentration declines to 50% of the steady state level in half-life. This is second section. B. Fixed dose, fixed time regimens. Administration of a drug by fixed doses rather than by continuous infusion is often more convenient. However, fixed doses given at fixed time intervals, such as with multiple IV injections or multiple oral administration, result in time dependent fluctuations in the circulating level of drug, which contrast with the smooth ascent of drug concentration observed with continuous infusion. 1 by 1.1 Effect of dosing frequency. The plasma concentration of a drug oscillates about a mean. Using smaller doses at shorter intervals reduces the amplitude of the swings in drug concentration. However, the steady state concentration of the drug and the rate at which the steady state is approached are not affected by the frequency of dosing. 1.2 Example of achievement of steady state using different dosage regimens. Curve B of figure 1.25, this blue color, shows the amount of drug in the body when 1 gram of drug is administered IV to a patient, and the dose is repeated at a time interval that corresponds to the half-life of the drug. At the end of the first dosing interval, zero point 0.5 units of drug remain from the first dose when the second dose is administered. At the end of the second dosing interval, 0.75 units are present when the third dose is taken. The minimal amount of drug during the dosing interval progressively increases and approaches a value of 1 unit, whereas the maximum value immediately following drug administration progressively approaches 2 units. Therefore, at the steady state, 1 unit of drug is lost during the dosing interval, which is exactly matched by the rate at which the drug is administered. That is, the rate in equals the rate out. As in the case for IV infusion, 90% of the steady state value is achieved in 3.3 times half-life. 1.3 Multiple oral administration. Most drugs that are administered on an outpatient basis are taken orally on a fixed regimen, such as a specific dose taken 1, 2, or 3 times daily. In contrast to drugs may be absorbed slowly and the plasma concentration of the drug is influenced absorption and the rate of drug elimination. See figure 1.26. Here, predicted plasma concentration of a drug given by repeated oral administration. The blue line is a single fixed dose. A single dose of drug given orally results in a single peak in plasma concentration followed by a continuous decline in drug level. The red color the red color line indicates repeated fixed dose. Repeated oral administration of a drug results in oscillations in plasma concentrations that are influenced by both the rate of drug absorption and the rate of drug elimination. The third section C is optimization of dose. The goal of therapy with the given drug is to achieve and maintain concentrations within a therapeutic response window while minimizing toxicity and or side effects. With careful titration, most drugs can achieve this goal if the therapeutic window of the drug is small. For example, digoxin, warfarin, and cyclosporin, a plasma concentration range within which therapy is effective, will be defined. The dosage required to maintain therapy will be computed and administered as maintenance dose or a loading dose when rapid effects are warranted, and drug concentrations are subsequently measured. The dosage and dosage frequency can then be adjusted if not within the therapeutic range. Number one, maintenance of dose. Drugs are generally administered to maintain a steady state concentration within the therapeutic window. To achieve a given concentration, the rate of administration and the rate of elimination of the drug are important. It takes 4 to 5 half-lives of a drug to achieve steady state systemic concentration. The dosing rate can be determined by knowing the target concentration in plasma Cp clearance Cl of the drug from the systemic circulation and the fraction F absorbed bioavailability. Dosing rate will be equal to target C plasma into clearance divided by F, that is fraction absorbed. Number 2, loading dose. A delay in achieving the desired plasma levels of drug may be clinically unacceptable. Therefore, a loading dose of drug can be injected as a single dose to achieve the desired plasma level rapidly, followed by an infusion to maintain the steady state maintenance dose. See figure 1.27. Accumulation of drug administered orally without a loading dose and with a single oral loading dose administered at t is equal to 0. Uh, th- this graph drug concentration in plasma versus time. Dosing started from 0 and the red spiral line is without loading dose while the blue spiral line is with loading dose. In general, the loading dose can be calculated as loading dose is equal to Vd desired steady state plasma concentration divided by F. For infusion, the bioavailability is 100% and the equation becomes loading dose equal to Vd into desired steady state plasma concentration. Loading doses can be given as a single dose or a series of doses. Loading doses are given if the time required to achieve half-life is relatively long, and the therapeutic benefit of the drug is required immediately, for example, lidocaine for arrhythmias. To loading dose, disadvantage to the use of loading doses include increased risk of drug toxicity and a longer time for the concentration of the drug to fall if excess drug level occurs. A loading dose is most useful for drugs that are eliminated from the body relatively slowly. Such drugs require only a low maintenance dose in order to keep the amount of the drug in the body at a therapeutic concentration. However, without an initial higher dose, it would take a long time for the amount of the drug in the body to reach a therapeutic value that corresponds to the steady state level. Number 3, dose adjustment. The amount of a drug administered for a given condition is optimized for an average patient. This approach overlooks interpatient variability, and in some instances, pharmacokinetic principles may be used to optimize therapy for a given individual or patient population while minimizing side effects or toxicities. Monitoring the drug and correlating it with therapeutic benefits provides another tool to individualize therapy. Note for drugs with low therapeutic indices, plasma concentrations are measured and dose adjustments made where appropriate. VD is useful because it can be used to calculate the amount of drug needed to achieve a desired plasma concentration. For example, assume the cardiac output of a heart failure patient is not well controlled due to inadequate plasma levels of digoxin. Suppose the concentration of the drug in the plasma is Cl and the desired level target concentration of digoxin known from clinical studies is C2. A higher concentration, the clinician needs to know how much additional drug should be administered to bring the circulating level of the drug from C1 to C2. Vd into Cl is equal to amount of drug initially in the body. Vd into C2 and A is equal to amount of drug in the body needed to achieve the desired plasma concentration. The difference between the two values is the additional dosage needed, which equals Vd into C2 minus C1. Figure 1.28 on next slide shows the time course of drug concentration when treatment is started or dose changed. Uh, Cumulation of drug following sustained administration and following changes in dosing. Oral dosing was at intervals of 50% of half-life. Here, this color line shows oral dose, and this color shows intravenous infusion. Drug concentration in plasma versus time graph. This is elimination half-life. The pink color line, the plasma concentration during oral therapy fluctuate around the steady state levels obtained with intravenous therapy. Here dosing changed. Dosages half and dosages doubled. When dosages are double, halved or stopped during steady state administration, the time required to achieve a new steady state level is independent of the route of administration. Our next presentation will be on signal transduction. Well, thank you for watching this presentation. If you have any questions, please write in the comment section below.